Hey everybody, this is Richard Slama, and today I hope to go over with you the Resident's Guide to Medical Resuscitation. Just as a disclaimer, I have no conflicts of interest, and although this is strictly for educational purposes and it's just my personal experience, you should always go by your departmental policies and what your institution governs as an appropriate way to perform a resuscitation. So why am I giving a screencast on this? I think I'm giving it because so many times especially when you see younger residents running a resuscitation, it is just complete chaos and completely disorganized. And I think that there's a lot of ways that we can improve upon that, especially if there's more of a standardized approach. And I don't think that there's a great standardized approach, at least that's written in many textbooks. So we're going to just start off with a case. So let's just pretend here that you have a 55-year-old male with severe hypotension. He's minimally responsive, he's altered, and he's being transported to the emergency department for evaluation. In this particular case, it doesn't really matter what the patient has, and this isn't, to emphasize the treatment of pulseless electrical activity or sepsis, anything along those lines. This is just to, how do you go about preparing your resuscitation? So the first answer is that you don't want to just go back to your computer and keep typing your notes and go about seeing other patients. You want to get ready. And there's a couple of things that I think are very, very important, particularly when you're dealing with a sick patient. So first is first. The airway is probably going to be the most essential aspect of any resuscitation, especially in patients who cannot protect their airway. So the three major things that I do, at least when I'm preparing for these, is I get my airway box, which will include my drugs, multiple different laryngoscopes, as well as laryngoscope blades. That will also include a stylet, the syringe, basically all the other supplies that you would need to intubate somebody, including the end-tidal CO2 monitor. I will always have a backup, and most of the time actually two backups. My first backup is the bougie, which is always behind me or on top of the bed when the patient comes in. And I will always have the glide scope immediately to my left, just to make sure that we have another good backup for when the patient comes in, just in case the first two options don't work. And on top of all this, you want to go ahead and hook up your bag valve mask to the back of the room, to your first port, and have that running at 15 liters. And then on the other side of the room, you want to hook up a nasal cannula. And the reason that you want to have this is, if you listen to any Weingart's talks, is that you want to be able to perform apneic oxygenation if you're going to intubate this patient. And the third thing you always want to have is your suction setup. So you go ahead and hook up all those things, you get them ready just in case you're going to be using them. Okay? And now just go into the other essentials. So I always bring the ultrasound in the room, and there's many, many reasons why I do this. The first of which is I always perform a rush exam on all of my sick patients. And this isn't always a full rush exam. I do it based on how the patient presents. But the reason I think that this has become so important, especially in our day and age, is that the ultrasound is a great way to guide your resuscitation. It guides your treatment. In particular, it can guide you as to whether or not you're going to use pressors or get fluid, or if you maybe need to get an EKG more precipitously than you would on another patient. You can check for pneumothoraxes. So I really think that if you're not bringing the ultrasound into the room and you're not using it to guide a resuscitation, you're really already putting yourself at a disadvantage. So some of the other things, and this will definitely be, based on the way that your patient's presenting. I don't open up a central line kit, but I have a central line kit in the room, just in case. And with that central line kit, I get the four major essentials. I get a whole bunch of flushes that can be dumped into the tray. I get a couple of chloride preps, because I like to prepare at least once or at least two times before I sterilely drape the patient. I get my caps because nobody ever seems to know where to find them, and I always get probe covers. So you get those major things in hand, you won't be scrambling around when and if your patient needs central access. Another thing I find really, really useful, especially for very, very sick patients, especially dialysis patients who have absolutely no access, I just always have the intraosseous line in the room. There's nothing worse than 4 different people trying to stick an IV in the patient and it's just not working. I give them about 30 seconds, and if there's not really any success with those attempts, then I just move straight to the IO so that we can start resuscitating the patient. So always have that in the room. Make sure that you have batteries that are brand new in your EZ-IO. And this is very, very much so based on the way that your patient's presenting, but in particular, if a patient is hypotensive and I think I'm going to need to intubate them, I think that they're at risk for death because of their hypotension in the peri-intubation period, then I will always mix up just some push-dose epinephrine. And this has been published a lot, especially on MCRIT and numerous other sites, but the basic way that you do it is you take 1 milliliter of 1 to 10,000 epinephrine, and that gets diluted into 9 mLs of normal saline. So that turns out to be 1 to 100,000 epinephrine. So every milliliter that you push of this mixed solution is 10 micrograms of epinephrine. And I use this in particular before I'm going to intubate somebody who is hypotensive to prevent cardiac arrest. And also to bridge them to vasopressor therapy, such as Levophed or any of the other pressors that you would use in these patients, because oftentimes those can take quite a while to get down from pharmacy. So a lot of times I will just mix this up just beforehand so I have it on hand when I need to use it. And some of the other things that you'll need, so I always, if there's not a respiratory tech available, I get the ventilator in the room, I make sure that it's turned on, I make sure that we have oxygen hooked up either to the wall or on the back of the machine, and just make sure that it's functioning appropriately. So, in summary, the resuscitation is sometimes a very, very chaotic environment. There's a lot of things that are going on at once. There's a lot of people trying to do things. There's been a lot of lectures on this before, and how to appropriately perform your resuscitations. This is more just how to organize all the chaos that you have. So I think if you prepare your room a little bit better, you get all the things that I've spoken about, at least in the room beforehand, and you're prepared to use them, and you have a plan set in place, that you can really turn chaos into organized chaos, and you can really improve the outcomes and expedite the care of your patients. All right. So that is all I have today. I appreciate you for listening, and if you have any other questions, please direct them to the comments in the blog or my own email. Thank you so much, and have a good day.